So, cardiovascular and pathology today. We're not doing pulmonary today. It's winter 2022. It's week 3. It's Tuesday. Off we go. So let's talk about thrombosis first. We've talked about it in lab this week, actually. Robbins has this, I don't know if it's a famous quote, but it's an interesting quote. Thrombosis is one of the scourges of modern man, because it underlies the most serious and common forms of cardiovascular disease, and that is true, including COVID-19. It is a killer. So thrombosis and embolism. So we've been talking about this quite a bit, but this is a thrombosis. It's a process of blood clotting. We shouldn't really call it clotting, even though it's kind of handy to say clotting. But this is a thrombosis, and this thrombus broke off, and once it breaks loose, remember this is a flowing river of blood. This flows downstream, and once it breaks off, it's called an embolism. And if the embolism makes it, if this is in the deep veins in the legs, you can see the valves here. If this makes it all the way into the lungs, it's called a pulmonary embolism. If it gets stuck in the kidney, you could call it a renal embolism. So wherever it gets stuck, I guess you could call it a cardiac embolism. They typically call it a saddle embolism if it gets stuck in the heart, because it has to be pretty big. Alright, we've got some definitions to do. So thrombosis, again, is the process of forming an unwanted blood clot. Thrombus is singular, thrombi is plural. This starts on epithelial or on endothelial cells, which is a form of epithelium, but it starts on endothelial cells. Remember, those are the cells that line the lumen of blood vessels and the heart, for that matter. If it happens in the vein, you can call it a venous thrombosis. If it happens in an artery, you can call it an arterial thrombosis, much more dangerous. Remember, we did this in lab yesterday, but remember the deep system of the lower extremities. So we'll start from the external iliac vein, turns into the common femoral vein, which splits into the deep femoral vein, and the femoral vein. You should never call this the superficial femoral vein, but it is an AK. It's a terrible AK, though, because this is the deep system. Turns into the popliteal vein, which splits into the posterior tibial, peroneal vein, and anterior tibial. And these go down and form the venous arches of the foot. And the superficial system, remember the key about this is 85% of all the blood in your lower extremity gets out of the lower extremity and into the inferior vena cava through this deep system. Superficial system, only 15% of the blood leaves. Most of the blood, especially down here in the lower part of the lower extremity, that's dumped into the deep system. But this is made up of the great saphenous vein, which goes down more in the medial part of the leg, and the small saphenous vein that goes more in the lateral part of the leg. And there's a bunch of tributaries. We won't worry about it. How does blood get from the superficial system to the deep system? There's these perforator veins that connect the superficial system to the deep system, and we did this in lab already, so we'll leave it at that. Let's go back to our definitions. So a DVT, or deep vein thrombosis, well, this means a blood clot, a thrombus has occurred in the deep system. So a DVT has to occur in one of these big pipes here. Got it? Superficial venous thrombosis has to occur in these superficial pipes here, usually the greater saphenous, or the small saphenous, or short saphenous, or lesser saphenous, whatever you want to call it. They tend to call it the small saphenous. These are not is different because a DVT, or blood clot in the superficial system, is not as dangerous because the flow of blood is is into the deep system. So the blood clots tend to get stuck in these perforator veins. There's perforators right there. they tend to get stuck in these perforator veins, and they can't go anywhere. They can't get into they're too big to get into the deep system. The deep system is dangerous because there's nothing from stopping that. If the thrombus breaks loose and becomes an embolism, there's nothing to stop that from going all the way into the heart, lungs, or kidney, or anywhere on the way up. Thrombosis or thrombus, we already said. Thrombus is an unwanted coagulation of blood. We already said that. Not histologically the same as a blood clot. Blood clots happen when an artery bursts and you leak blood outside of the vessel, and the clotting that occurs is called a blood clot. Or if you get a rip in the tunica media, like with a dissecting aneurysm, the blood that thickens up and clots is called a blood clot if it's inside the wall of the vessel. But when it's in the lumen of the vessel, it's called thrombosis. Embolism, we already said, is a piece of thrombus that is broken loose, and it can get stuck anywhere. In the lungs, it's called a pulmonary embolism. In the heart, it's called a cardiac embolism, a hepatic embolism if it gets stuck in the liver. Remember, these all come from, let's say, the popliteal vein is where you develop this embolism. Or get stuck in the adrenal gland, it's adrenal gland, or adrenal embolism. You get the deal there. You get the story. More definitions. A thromboembolism, you might hear that word. So embolism means thrombus has broken loose, so a piece of thrombus has broken loose, and that's called a thromboembolism. The arterial thromboembolism just means that the thrombus has occurred. The embolism, the origin of the embolism is from an artery. A venous thromboembolism means it came from a vein, had thrombus, and formed an embolism. Sometimes that's called a VTE or just venous embolism. Pulmonary thromboembolism means that it's kind of assumed when you see pulmonary thromboembolism, it's assumed it comes from the deep veins. So you can just assume that there was thrombus in the deep veins, it broke loose and became an embolism, and it got stuck in pulmonary, which means lungs. See how that works? So thrombophilia. Philia is you like to do something. Thrombo is you like to form thrombosis. So this is a blood clotter. This is someone who clots too easily. Don't really say clots too easily. That's kind of slang. But you could say these thrombophiliacs have a prothrombogenic disease. Pro means yes. Thrombo means thrombosis. Genic means the process of. So they like to form thrombus. Or you could say the person is in a hypercoagulable state. Coagulation means basically forming a blood clot or forming thrombus. And hyper means they do this too much. So they form blood clots too much, or just a coagulable state. Coagulopathy, authors often use coagulopathy to mean a thrombophilia, or you have a clotting state of your blood, but it's not a good term, and they really shouldn't use it, because coagulopathy means there's a problem with blood coagulation, but maybe the problem is it doesn't coagulate enough, and you're a bleeder, you're a hemophiliac. So watch out for that one. If you see this, hopefully they've weeded all those out of the board questions, but that's a terrible AKA for hypercoagulable state. So watch out for that one. I will use it correctly. That's a general term, and it could mean you're a thrombophiliac or a hemophiliac. Coagulopathy, we just said that. Right? Person has just everything I just said. Patient has a blood condition which either prevents blood from clotting properly, so they would be a bleeder. They're a hemophiliac, or they have hemophilia. Hemo is blood. Philia is likes to do something. So they like to blood. Like to blood means like to bleed. Or they have a hypocoagulable state. Watch out for my tests. Always look for hypo versus hypercoagulable state. I could throw that in there. A lot of people missed that last quarter. So make sure you read my words carefully. Or coagulopathy, as we said, it can make the blood clot too quickly, too aggressively, and then you're in a hypercoagulable state where you coagulate too much, and then you're a thrombophiliac or have thrombophilia. Make sure you know the difference between thrombophilia, meaning you're a clotter, and hemophilia, meaning you're a bleeder. All right, enough definitions for now. Let's get into factor V Leiden mutation. This is a very important guarantee. You're going to be tested on this. Stars all over the place. So a very common AKA, which I like to use, is activated protein C resistance to see if you remember your general pathology. It is the most common congenital cause of a hypercoagulable state. So congenital means you're born with this problem. And hypercoagulable means you're a clotter. You like to clot blood, and it's the most common cause. Okay, so those who have activated protein C resistance, aka factor V Leiden mutation, which is the more common term, these people are in a hypercoagulable state. They are thrombophiliacs. They have thrombophilia. And yeah, they're blood clotters. Okay, again, it's the most common genetic congenital, meaning you're born with this risk factor for developing a blood clot or thrombosis. And testing for factor V Leiden mutation, if you get an embolism, pulmonary embolism, or you just get a thrombus formation, which hurts very bad at the end stage of it, you go into the ER and you get it taken care of through heparin and other blood clotting, anti-clotting mechanisms. After you get it fixed, you better find out what caused it. And so they always order this test to make sure you don't have factor V Leiden mutation. It's a very common test. So where does this activated protein C, APC, come from? Well, remember what that is. Remember, APC is a major inhibitor of the blood clotting cascade. And it has a double duty. It can bind to and kind of stop the function of factor V and factor VIII. It shuts them off. So once your leaking blood vessel is clotted and patched from this coagulation process, you don't need to keep clotting, so you need to turn that off. So activated protein C stops the blood clot from getting out of control. It stops a simple coagulation or a patching of a vessel wall that's ruptured from going crazy and blocking the whole lumen. So activated protein C is very important. Remember, factor V and factor VIII are kind of brothers or cousins, close cousins. They're called homologs. They're very similar looking molecules. Remember what they do? They convert prothrombin to thrombin, which converts fibrinogen to the main blood clotting ingredient, which is fibrin. In fact, fibrin, a mix of fibrin and red blood cells, is what makes a venous thrombosis. So you should know that. Oh, Alexa is talking. Alexa, stop. My God, that Alexa. I should have listened to see what she thought I said. Oh, she probably heard me say fibrin. I didn't say Alexa, though. Anyway, so fibrin plus red blood cells is what a venous thrombus is made of. Interestingly, it's not what an arterial thrombus is made of. There are believed to be different mechanisms of clotting with regard to arterial versus venous blood. Arterial thrombus is made mainly of platelets, which is kind of weird. You don't have to memorize this, but I mean for boards you need to remember this. But just to show you how important factor VIII and V are, factor V in particular is involved in both the intrinsic and intrinsic pathways that ultimately produce fibrin. And so important. Here's a very cool picture. So this is a venous thrombus that is formed in a popliteal vessel and put under electron microscope, and you can see all the fibrin like spider webs and all the red blood cells, which are called entangled in here, and that's exactly what thrombus is, a venous thrombus, not arterial thrombus. So what is the deal? What is this? Let's talk more about this factor V Leiden mutation. It's usually a single point mutation on the gene. I used to have the gene information. We won't worry about the gene. We'll just call it one of the genes on one of the chromosomes that makes factor V. So a point mutation, specifically that means that an arginine is replaced by glutamic acid or glutamine, whichever you want to call that. And that one misplaced amino acid causes a conformation change in APC, or not in APC, in factor V. So the mutation is in factor V. And because of the mutation, the binding site for APC is messed up. So let's do it again. So we have a single point mutation in the gene that makes factor V. Specifically, it's an arginine replaced by glutamic acid, and that causes a shift in the shape of factor V in such a way that the Turner off, or APC, can't dock to factor V, and therefore there's nothing to stop factor V from running wild and making too much of a blood clot. Okay, so mutation gives rise to a dysfunctional binding site, so APC can't bind to factor V. Note that the mutated factor V still can clot blood. It can still stimulate the coagulation cascade, no problem. But the problem is you can't turn it off, and therefore you clot or you develop thrombus. And APC, is the research has shown, it can still bind a little bit to the mutated factor V, but not very well. It's 10 times less likely to bind. So the binding affinity to factor V, is greatly decreased. So what's the risk? Well, the risk is you're going to clot. So these people with factor V Leiden mutations, they are always in a hypercoagulable state. They're thrombophiliacs. So they're at risk for venous thromboembolism and venous thrombosis, which can progress into an embolism, venous thromboembolism, which could probably end up as a venous pulmonary thromboembolism. See how all those words work. Some specifics. So if the mutation is only one gene, you have a 8 times, or your increase of developing a thromboembolism, meaning that the embolism occurred, is a factor 8. It's increased by a factor of 8, which is significant. Even a factor of 2 or 3 is not the greatest, but that's concerning. If you're homozygous, meaning both genes are mutated, and you're making all of your factor V is mutated and can't bind APC well, you're at 100 times risk for developing thrombus in a deep vein that breaks loose. That's the key. Much higher for people who just develop venous thrombosis, and it doesn't, because it doesn't always embolize. Sometimes the body can naturally take care of it. Venous versus arterial thrombosis. So again, the research is a little mixed on this. The question is, do factor V Leiden mutation people, do they also have a risk of developing the much more dangerous arterial thrombosis and arterial thromboembolisms? And the research is mixed on that. Some good research says no, which suggests that there is a different coagulation pathway between venous and arterial coagulation. So we're not 100% sure on that. Back to some definitions. A hematoma, that is a formation or a blood clot outside of the lumen or in the tunica media. You shouldn't call that, you don't get thrombus outside of the blood vessel or even in the middle of the wall of the blood vessel. All right, so that's enough about that. Let's switch gears. Let's talk about the lymph system, diseases of the lymph system. All right, and remember the lymph system, we talked about that a lot. So we have these microcirculation and capillaries all over the body. We have these blind-ended lymph capillaries that suck excess interstitial fluid up all the time. And that interstitial fluid is heading up toward the subclavian veins to be dumped back into the bloodstream. And we call the interstitial fluid, once it gets into the lymph vessel, we call it lymph fluid. Very important at keeping your tissue dry, so to speak, so you don't have an overabundance of blood fluid. Super important. But the question is, what happens if you get a beaver dam? And I don't know why I can't see my drawing tools here. But what happens if the flow of lymph fluid is this way? Let's say the head is up here. What happens if you get a beaver dam here? What if you get a bug, or you get cancer growing in here, or you get a tumor growing in here? Well, it's a beaver dam. Everything upstream of the beaver dam, the pressure will start to rise and back up. And the backup occurs right into the interstitium. So the interstitial fluid swells up because you can't drain off the excess interstitial fluid. And that's lymphedema. So anything that backs the flow of lymph fluid through the beaver, it becomes the beaver dam scenario. Everything I just said there. Okay, so let's look at an example. So here's someone who had a mastectomy for breast cancer. And the surgeons had to remove the lymph nodes in the axilla. And they tried to tie off the big ones, or not tie off, but they tried to connect the bigger lymph vessels into the venous system. It's one way to do it, and it doesn't work that good. About 20% of people end up with a beaver dam in the lymph system. And so this is all interstitial fluid, really lymph fluid, combination of lymph fluid and interstitial fluid that is backed up. This fluid is waiting its turn to get through the crummy lymph circulatory system because of the removed axillary lymph nodes. So that's called lymphedema. If you know the cause of it, call it lymphedema. If you're not sure, you just call it swelling to be safe. But with a history of breast cancer and mastectomy with axillary node removal, we know this is lymphedema. So how do you, is this person in danger? Is the skin in danger? Well, it depends how bad the lymphedema is, because the circulation in this arm isn't the greatest. Everything's all backed up. So you do have some trouble. If you have, remember that little fish diagram where you have too many water molecules in the interstitium and you were trying to get a glucose molecule to feed a cell, and it's having trouble reaching the cell because of all those water molecules. So the same thing, oh, here it is right here. So if you have the interstitium overfilled with water molecules because the lymph system can't drain these extra fish away, well, glucose and oxygen and nitrogen, they have trouble feeding the cells, and the cells can start to die. They can start to hurt, and you can get ulcers and gangrene and the whole 9 yards from this thing. So yeah, they can occur. When larger caliber, the bigger caliber lymph vessels, if they get clogged and beaver dammed, you have more of a problem. So that's just kind of intuitive here. Nice picture though, right? Remember, we have these nice valves in lymph vessels as well, because there's no pump here to pump blood up toward the subclavian veins. So just the movement of the body squishes the blood fluid or the lymph fluid up, and then if you rust and freeze, the blood fluid will be pushed down by gravity, but these valves will pop open and catch it. So it's ratcheted forward toward the subclavian vein, but they're everywhere. Look at the lymph vessels. They're everywhere. If you do get a large caliber beaver dam or blockage, you can sometimes even rupture these things. The backup can be so great. They're not super strong like arteries, so you can rupture them and get some major lymphedema. Lymph disease, it usually affects the extremities. It can happen inside of organs, but you can't see that. We can divide lymphedema into two parts, primary and secondary. Let's take a look at primary first. This is sometimes called hereditary lymphedema because you're born with this problem usually, or congenital lymphedema. And you're born with a defective lymph system. The pipes aren't formed correctly. Specifically, here's a normal looking lymph pipe here. They're super stenosed, so you're born with very stenotic lymph vessels, and therefore you just can't clear lymph fluid very well. Or maybe even worse, you're born with no lymph vessels, and you just are always swollen. These people are always swollen because the distal capillary can't drain excess lymph fluid or excess interstitial fluid out. There's no way to clear the lymph or the interstitial fluid without lymph vessels. Or maybe you were born with a problem with these little valves right here and they don't work. Or maybe they've been damaged by a previous infection. So these are all risks, but these are called primary lymphedema conditions. Okay, you're born with these problems. That was a bad example of an inflammation, though. That would be a secondary problem. But if you're born with no valves or you're born with short valves, that would be an example of primary lymphedema. My voice is going out already. Let's see. Yep, so faulty stenosis of valves, of course, cause the Beaver Dam scenario, and you get lymphedema upstream. Remember upstream. So, looks like, well, the direction of flow is going that way. It's kind of weird. I'd rather have it going to the head, but if the flow of lymph is this way, the Beaver Dam occurs here. This is going to swell, and lymph fluid is going to be draining out here, and interstitial fluid is going to be building up. That's upstream. So make sure you understand that's upstream is this way. Downstream from the Beaver Dam would be this way. Okay. Let's see. Yeah, these are fairly rare. Primary lymphedema conditions. In fact, there's only one that I'm going to talk about. It's kind of where I live in Gilroy. Milroy's disease. Super rare, though. It occurs about 1 out of 6,000 births, so it's 0.001. How rare is that? Blood clots with the J&J vaccine, where people were freaking out, that's 0.0001% of the population. Chances of winning the lottery is 0.0003% of the population, so it's pretty rare that this occurs. But let's talk about it anyway. It's a gene mutation that leads to the formation, the embryologic formation of very narrow lymph vessels, or in some cases, no lymph vessels, no smaller lymph vessels. And that's not good. If you have narrow lymph vessels, your interstitial fluid is always going to be too much, and your tissue is always going to be puffy, and you can never properly drain because you don't have a mechanism to drain that excess interstitial fluid off. So here's a baby who was born with Milroy's disease, and his whole body's like this. You can see his feet are all puffy, his toes are all puffy, and there's no way to, there's no fix for this. He just has to live with this and wear compression stockings. And they're trying to work on rerouting things, but they're not. This is just a bummer to be born with this. There's some also associated problems if you have Milroy's disease. Over a third of those with Milroy's disease also have hydrocele, which is testicular swelling. We'll talk about that when the time comes. Varicosities, about 25% have. They almost always have these weird up-slanting toenails. See how these are scooped out? So, and that's not from the swelling. They're just they're concave toenails. So that's also diagnostic of Milroy's disease. Now let's get to the more common ones. Secondary lymphedema means that you are born with a good lymph system. There's nothing wrong with it, but something happened to it that caused a blockage of lymph flow. So it's a new blockage in a previously normal system. And usually affects big lymph vessels like the axillary, the vessels that go through the axilla. Remember, primary lymphedema usually affected the smaller lymph vessels. Secondary lymphedema affects the bigger lymph vessels. All right, so this is a major beaver dam problem. What are the causes? What can go wrong? By far, the number one cause is surgical removal of lymph nodes. Probably you're looking for cancer, or the lymph nodes have snagged a bunch of cancer cells. And in order to prevent that cancer from spreading further into the body, you have to take them out. And then the surgeons can reconnect the end of the major lymph vessels to veins and try to reroute them, but it's not very successful because scar tissue forms after the ends heal together, and it causes a beaver dam. It's said to occur in about 5% of all surgical cases. Okay, another, more not so much in our part of the world, but the number one worldwide cause of secondary lymphedema is a parasitic infection. And that's almost always by that W. bancrofti we've talked about before. It's a bug who just loves to go inside of lymph vessels for whatever weird reason. And so if you got this bug inside the pipes, it takes up space and it acts as a beaver dam. And plus the bug can stick to the valves and burrow in there and try to breed there. The body can spot it and mount an inflammatory response. And and just the inflammatory juice and swelling can act as a beaver dam. And after the swelling is gone, remember the end phase of the inflammation process is scar tissue. So fibroblasts lay down scar tissue and can scar up the lumen of the lymph vessel. Right, some other causes. So the chemotherapy and the radiation can damage delicate lymph vessels all by themselves and cause an inflammation. The inflammation can be fibroblast heavy and tends to lay down scar tissue within the vessel. So cancer can kind of be, breast cancer for example, can be a double whammy. They remove the breast and lymph nodes. That increases the chances of lymphedema in the arm. And then they do chemotherapy, which again damages the lymph system. Another condition is neurofibromatosis 1. You should definitely know that. That's you get these little tumors that grow all over the body. Here is a condition. Here's a patient with neurofibromatosis 1. And what we can't see, a lot of these go way down into the dermis and even subcutaneous layers or the third layer down. Note the cafe au lait spot, classic with people with neurofibromatosis 1. All right, and yeah, if the tumor is affecting one of the major lymph vessels of the lower extremity, you can get this situation. So this is all lymph fluid that's accumulating. It's interstitial fluid that is built up in the tissues, waiting for its chance to get through. And it looks like they've had a big surgery here. Big cafe au lait spot right here in this patient. This leg is not affected nearly as much. It's a little puffy, but there's a lot of tumors. They're not visible on the skin in this patient, but yeah. You can have primary tumors can grow within lymph vessels, or you can have, probably more commonly, you can have cancer somewhere else, like malignant melanoma, which loves to get into the lymph system. You can have cancer cells get sucked up into the lymph capillaries and get stuck in the lymph vessel wall and grow there and physically cause a beaver dam. And as they grow into the vessel wall, the body's immune system sees them, and you get an inflammation which further narrows the lymph vessel. Here's a case, 73-year-old female, status post-right mastectomy. That means she's just had the mastectomy, which worked well, but unfortunately the lymph nodes had to be removed, and you can see the result of this. She's swollen up like crazy. And yep, to make things worse, she had to have chemotherapy, which further damaged the vessels. Even the other side, look at her ring, see how tight the ring is there? So both arms are affected by the chemotherapy. And this one was affected by the chemotherapy and the surgery. So this is an example of secondary lymphedema. And just an article that was up, how they're trying now in San Diego, and there's other places that are doing this. They're trying to reconnect after they take out a lymph node. They're trying microsurgical techniques to try to put the ends of the vessels together to help that, because 20% of people are ending up with swelling after mastectomy, ending up with lymphedema. All right, some more definitions. All right, I had a system crash, so let's finish up this lecture here. So we left off on lymphangiitis. I can't remember if I talked about this slide or not, but let's do it again. So itis means inflammation. So we have an acute inflammation of the lymph vessel. Angio is like a vessel, and is typically caused by a bacteria somewhere upstream from where the infection is. Right. And we can see the infection from the skin, as we'll see here in a second. The bugs are typically beta hemolytic streptococci, is the most common culprit with lymphangiitis. And it results in visible red erythemic streaks on the affected extremity, just like this. So if we got, now I can draw at least since I restarted this. So if we get, let's say, an injury right here, and we get a lesion, I don't know, a bug bite, or we got a cut here, and bugs, strep got in here, or you just call them bugs, and the bugs got into the little blood vessel, or into the little lymph system, and the bugs started to travel up toward the bigger lymph nodes in the inguinal region. But these bugs are so wicked that they're able to dig into the walls of the lymph vessel and cling there and start to breed. And of course the body recognizes that and attacks them, so you get an inflammation of the bug-filled lymph vessel. Right? So the inflammation rages and you start to get visible erythema on top of the lymph vessel, and it's gotten into the skin as well. It's went out of the blood vessel, or out of the lymph vessel, and it's worked its way into the skin itself. Okay, so that's not good, because you got bugs headed for the circulatory system. I mean, this will also ultimately dump up by the subclavian veins, and you could get a septicemia, which is a very dangerous situation. All right, and the bugs, so here the bugs have spread out of the lymph vessel a little bit, gotten into the skin, but if they're very, very aggressive bugs, they can take over the entire skin. Right? So here they're isolated to a region just on top of the lymph vessel. But if it's a very aggressive bug, it can start to take over the entire surface of the skin here, or the foot. And that's not good. So that's called a cellulitis. And we need to talk about that, because that's getting close to septicemia, which can be fatal in a large amount of cases. So let's talk about cellulitis. All right, so it's an infection-driven inflammation of the deep dermis and subcutaneous tissue. So it's kind of an infection. We're used to infections starting on the surface of the skin and going down. These come from down and go upwards. So it gets out of the lymph vessel, gets into the subcutaneous tissue, and spreads into the deep dermis and becomes visible on the skin. Because of the inflammation, of course, is driven by cytokine release, and that's that same story I say over and over again. But yeah, and you check if you go way upstream. I mean, if we go back to this picture, if we go up to this guy and check his inguinal lymph nodes, they're going to be inflamed. You'll be able to palpate inflamed or you probably by this point will be able to palpate big, inflamed, tender lymph nodes. Okay, so, and that would be called lymphadenopathy, and we'll get into that more next time. Well, I'll tell you right now, lymphadenopathy is a swollen lymph node that is not red. It hasn't gotten into the skin. So if it's a swollen lymph node and the skin is red over the top of it, it's called lymphadenitis. Okay, 14 million cases occur each year, $3.7 billion in medical treatment. About 65,000 hospitalizations are necessary each year. And the number one bug of cellulitis is is a beta hemolytic streptococci like Streptococcus pyogenes, which looks like these little great beads here. Or Staph aureus can also do it. That's the number two most common. High immunocompromised people are at high risk. We'll look at a list of risks here in a minute. More signs, so fever and chill, malaise, flu-like symptoms means that the bugs are starting to get into the blood. Remember this massive bug infection, they were part of the inflammation process is release of cytokines and chemokines which stimulate the fever mechanisms. So you can start to get flu-like symptoms from these things as well. And yeah, very dangerous. Stepping stone to septicemia. All right, look at this guy. That's crazy. I think this one started with a cut underneath the foot, and it got into the lymph vessels. The bug came out of the lymph node vessels and have infected the subcutaneous tissue, and now they've infected the dermis. So this is classic cellulitis here, and it's very dangerous. All right, you go up palpate inguinal lymph nodes, they're going to be swollen. What are the risk factors? Immunocompromised people, or if you're on immunosuppressant therapy, you're at high risk because the infection can't knock out these bugs like it's supposed to. If you have a bunch of swelling in your foot, we talked about that, from lymphedema, from venous stasis, from whatever the cause. If you're swollen to begin with, you're at risk for this bug infection because you can't get the lymph system, or you can't get the troops in to beat up the bugs that are causing the inflammation. Why can't you get the troops in? Because the troops have to come out of the bloodstream and swim through the interstitium. And if the interstitium is filled up with zillions of water molecules because you're swollen, it's hard to get the troops in to fight the battle. So that's how that mechanism works. In diabetes, you can't get the troops into the tissue because blood vessels are usually narrowed. PAD blood vessels are narrowed. HIV blood vessels are narrowed, and all sorts of reasons for that. So yeah, these are some of these. And I love this. Is an easy slide for me to make a test on, right? If the bugs kind of pool in one area and really multiply and start destroying and feeding on tissue, you can literally get holes in your skin, which are filled with pus and inflammatory juices, and that's called an abscess. MRSA is particularly notorious for causing abscesses. That's methicillin-resistant, staphylococcus-resistant bacteria, and yeah, that's an abscess. And sure, the abscess can kill tissue, and you can even get hemorrhage if it gets down into the subcutaneous tissue and hits some big blood vessels, and it's a medical emergency. There's a diabetic who got a simple bug bite, and the bugs got into the lymph system and spread out. They moved out of the lymph system into the subcutaneous tissue and now have gotten into the dermis, and you can see the wicked inflammation that's going on here. Same thing here, only this time we have pockets of bug parties where bugs are breeding and horrible destructive inflammation is occurring in these spots, and that's an abscess. How do you treat this? Major antibiotics, a 10-day course of oral antibiotics for simple. You might have to be hospitalized and put on intravenous antibiotics if it's gotten to this point. They want you to elevate the limb. Anything to remove swelling from the area helps the troops get through the interstitium to attack the bugs. So elevate, compression, wet dressings, and they want you to avoid any type of painkillers, because if the infection gets into the deep subcutaneous tissue, it's going to be severe pain. You need to go to the hospital because the oral antibiotics aren't working. You need to be on IV antibiotics at that point. All right, so that is the end of the presentation. Sorry about the technical difficulties. One of my favorite pictures ever. And remember, I've been known to throw these pictures on the extra credit questions. I've even threw it in the real test before. Got to know your wildlife, right? You're gonna have kids. One of your kids might love birds, and you need to know a little bit about the birds. This is a great horned owl, young great horned owl I got over the break, and the sun has long gone down. This is pretty much dark. I could still walk back to my car, barely find the trail after this is over, so difficult shot to take, but that is a great horned owl. See you guys later.